Good afternoon, everybody. Thank you for joining us for today's CIVHC Connect meeting. And we're going to talk about our public reporting from the Colorado All-Payer Claims Database. Again, we appreciate all of you joining us this afternoon. If you are on the West Coast, good morning still. We have, I think, people from all across the nation tuning in today. My name is Carrie Frank, and I'm VP of Communication and Marketing, and this is my partner in crime here, Maria de Jesus Diaz-Perez, and she's the Director of Public Reporting. We'll be kind of tag teaming this webinar today for you guys, so we'll be going back and forth with some of our slides. I just wanted to mention some housekeeping items really quickly before we get started. All your lines are muted. We will be saving most of the questions for the end, but feel free to use your Q&A box on your webinar here today to type in your questions as we go. And if there is something pertinent we need to address right at that moment in time, we will go ahead and do that. But otherwise, we'll be saving most of the questions and answer sessions for the end of today's webinar. We are recording this webinar, and it will be available on our website within the week. We also will be posting the slides that we're showing today, as well as a summary document that we have put together that goes over all of our public reporting and everything that's available in our public reporting space. So without further ado, we'll go ahead and get moving on the slides here. So just a quick agenda today. We will go over just a little bit more about CIVHC for any of you joining us today who aren't very familiar with our organization or the Colorado All-Payer Claims Database. We'll review public reports that are available now and are also future plans for public reporting, and talk about the things that are available, including our interactive reports, spot analysis, and data bites. And then we will open it up for questions and answers. And we really do want these CIVHC Connect meetings to be interactive. And I'm sorry for those of you who weren't able to join us for the in-person meeting. Last week we had a great discussion with the group there. So we will be holding these on a quarterly basis and talking about some of the work that we do to support change agents throughout the state and country. And so if you are able to ever join us for those quarterly meetings, we would love to have you in person. But again, thanks for joining via webinar today. Just really quickly about who we are. It is our mission to empower and support individuals, communities, and organizations throughout, again, Colorado, and we also support those nationally who are working to improve the triple aim of better health, better care, and lower costs. We do that in a number of different ways, but we really think of anyone touching healthcare, including consumers who are using healthcare, as our change agents who we support. So that includes employers, researchers, government agencies, consumers, advocacy organizations, health insurers, you name it, providers across the sphere who are working to make healthcare better and cheaper and higher quality for all of us. We have three main focus areas at CIVHC. We think of our work in buckets of transparency, healthcare reimbursement, and also care delivery. Data transparency is a lot of what we're going to talk about today with our work as the administrator of the Colorado All-Payer Claims Database on behalf of the state. We also look for ways to support those who are in the space of healthcare reimbursement changes that will drive higher value into the system. And then also on the care delivery side, looking for innovative ways that we can change healthcare delivery through programs like care transitions and palliative care as two of our primary areas of focus right now. So a little bit more detail about the Colorado All-Payer Claims Database. In 2008, it was recommended by the Blue Ribbon Commission for Healthcare Reform. In 2010, it was legislated in House Bill 10-1330, and we were also named the administrator by the Department of Healthcare Policy and Financing. Since 2010, in 2012, it was actually launched, and we were able to provide the first public transparent data on our website. And we also began creating custom requests right shortly after that in the beginning of 2013. And since 2013, we've really been enhancing the website. We've been expanding available reporting that we have publicly. We've also expanded the number of custom reports and analysis that we've been able to provide to change agents across the state and country. And we've also gone through a big transition phase with a new vendor too, and that went into effect last July. So we do have a new data warehouse vendor as well, which we're very excited about. So what's in the CO APCD? We have a lot of information. It represents the majority of insured Coloradans across Medicaid, Medicare, and Medicare Advantage, and then also the 33 largest commercial payers in the state. That represents about 750 million medical, pharmacy, and dental claims, and that we get claims on a monthly basis, so that number increases every single month. And it's about approximately 4.3 million unique lives in the state of Colorado. So again, that is the majority of covered insured Coloradans. So what do we do with that information? So all of those claims come into us, and then we turn that information into actionable data, both on a public basis and a non-public basis. So again, what we're going to talk about mostly today is what we have available on the public side through our website. And really, we think of our public data as a way for us to educate folks about healthcare issues that we're seeing in the data. There's a lot of variation in healthcare, whether you're looking at cost or quality or utilization or even prevalence of conditions. It's very different depending on the part of the state that you're looking at. So part of the reason we do this is to educate folks about where that variation exists and where we have also opportunities to inform cost savings and improved care. And we also think of it as really supporting decision-making at the community level with new programs or new initiatives to see where you might have opportunities to make changes, and then also track progress and evaluate how we are doing in those initiatives and in those programs, and as a state, how we're moving the needle on healthcare. I'm going to hand it over to Maria to talk about our interactive statewide report.
Hello, everyone again. As Carrie mentioned, we are going to talk about the new release reports in our public website. And we're going to walk through all these 4 reports. They have been released starting fall 2018. And these reports measure 4 different aspects of the healthcare system performance in Colorado. We have a report about cost, a report about healthcare quality, one about utilization, and one about condition prevalence. We have also some exciting updates coming up, and we're going to talk about that later also. The first report that we released in fall 2017 was about cost, and I know that cost of healthcare is one of the main topics of conversation for like policy advocates, for providers, and also for consumers, of course. And as the cost of care report, or let me back down a little bit because I'm going to talk about the 4 reports, and I want to tell you something about the 4 reports in general. One thing to keep in mind first is that the population, or what you are seeing represented in the 4 reports, is, as Carrie explained, all the insured population in Colorado. So when you read that these numbers, please keep in mind that you are just looking at the population who are covered, and what is represented is the healthcare services that have been paid to providers by a third payer. That means by a commercial or by a public health insurance plan. That's just for you to keep in mind when you're reading these data. And going back to the cost of care is defined here as the amount that is paid to the providers, whether by the health plan or by the member. And we are presenting the cost of care divided in 4 service categories. We are presenting the cost for outpatient services, inpatient, professional, and pharmacy. And all the reports share a common layout. The first report, or the first page of the report, is going to be an overview of the topics that is presented in that report, and you can see just the breakdown by payer and the breakdown by rural and urban populations. Then you move to the second report, which mainly features the change over time on the cost. And you move to the third report, and the third report is going to show mostly the variation across the geography in the state. So you're going to have a map, and you can see the cost of care displayed at the county level or at the health statistical region level, and then you can compare how the county looks against the state median for that specific measure. And the cost of care report, what are the highlights of the cost of care? I think the highlights are pretty much not very surprising for most of you. One of the things is that the costs have increased. The costs in general of healthcare services have increased. It takes about the median cost for the per person per payer in Colorado is $4,000 in the state in general. But I think the best or the huge highlight in this report is the variation. The cost of care in some rural counties is completely different than the cost of care in urban counties, and you can pay out of pocket for Medicare members, Medicare Advantage members, $600 in urban counties compared to $1,000 in rural counties. Also, one of the highlights of this report is the largest increase in cost of care is in pharmacy services, and the increase goes from $400 in 2012 to about $900 in 2015. These reports, I forgot to mention, that go from 2012 to 2015, and all the reports have exactly the same years. So if we move to the next report that we have is the utilization report. Utilization is just in general how Coloradans are using or what services are they using. We have different service categories also. We are displaying unplanned hospitalizations, and it is pretty self-descriptive. That means all the acute inpatient events that consumers didn't plan for it. For example, a delivery is not counted here because a delivery is something that you usually plan for, and some surgical procedures are not included either, like a hip replacement, for example. We have also 30-day readmission, which is all the discharges that are readmitted in the hospitals within 30 days. Outpatient services, which are all the services that are received in an outpatient facility, including ambulatory surgical centers. We have ER visits, which are all the emergency room visits for any reason, and that didn't end up in a hospitalization, and that is an important distinction. Then we have also observation stays that include all the events where the patients were kept for medical and evaluation, but for medical like surveillance and evaluation, but were not admitted to the hospital, and pharmacy scripts that include also generic as a subset of the total pharmacy scripts. All these measures are represented as rates, and the rate is the number of events per 1,000 people. And in this case, again, the 1,000 people is the 1,000 insured members included in the APCD. The report has exactly the same layout than the other reports, and if we have time, we can go over some of the features of the interactive reports. Some of the highlights of the utilization reports is that the emergency room visits have increased over time, at least in these years that we measured, 2012 to 2015. The good news is that the rate didn't increase for Medicaid population. However, it's good to keep in mind that they still have the highest rates of emergency room utilization. Unplanned hospitalizations, which of course are not desirable, also increased. And but again, the main story of the utilization report is the huge variation. You can see that the emergency room visits, for example, the rates are considerably higher in the southeast part of the state. Okay, the next report is quality, and I'm going to make a pause here. I know that I am going over this a little quick, but I want to leave a lot of time at the end for your questions and comments, because that's actually the fun part. We're just walking through the content of the report. Quality, I think by now everybody is familiar with quality of care, but I am still going to read the main definition of quality, which is the definition on that groundbreaking report that now is very old, but that was put out by the Institute of Medicine. And quality of healthcare is defined as the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. That's quality in general, and quality has many different aspects, from increasing access, timely access to healthcare, to improving equity. But there are some specific aspects of the quality of healthcare that are covered or that are approached in this report. We have just two sets of measures. We have preventive measures, which is all the appropriate care that is used to increase or to increase healthy outcomes in a population and to prevent problems. And the three measures that we have here is breast cancer screening, cervical cancer screening, and colorectal cancer screening. And breast cancer screening is all women between 50 and 74 years old who had a mammogram in the last 2 years. Cervical cancer screening is for women 21 to 64 who had a PAP in the last 3 years, or in the last 5 years if they are 30 years old and had an HPV test at the same time that they had their PAP. Colorectal cancer screening measures all the population who are 50 to 75-year-olds who had appropriate colorectal cancer screening, and that includes colonoscopy in the last 10 years, the fecal immunological test or the FOBT, fecal immunological blood test in the last year, or the sigmoidoscopy in the last 5 years. It is important to note here that the history of claims data doesn't go as far as 10 years, so this measure might be a little underrepresented because of that reason. And also keep in mind that we talked in the beginning, these reports represent the recorded healthcare services that are billed to a third payer. So if anyone receives a service free of charge somewhere else, that is not going to be captured in these reports. Okay, so the other set of measures that we are presenting here, or the two examples is the appropriate treatment. An appropriate treatment is, as the definition says, treatment that is consistent with current professional knowledge. And appropriate treatment for asthma is one of the measures that we have here, and the other measure is diabetes A1C. That means that all the patients who have diabetes received an A1C test at least once in the calendar year. Those are the two sets of measures. So please go and check them out, but we're going to go through the highlights. In general, we can tell that the healthcare system seems to be doing better for the patients who already have a disease, because they are already engaged with the healthcare system and they are receiving some services. Still, you can see that 1 in 4 patients with diabetes did not have an A1C recorded in the last 12 months. So that's actually of note. But I always like to put more attention in the preventive screening, because there is so much opportunity, or so many missed opportunities of actually improving the health of the population by using more preventive screening. And I think we still have a long way to go. One of the best stories is that you can see in the reports how breast cancer screening has increased, but you can still see a huge difference, and that's the one that is always more noticeable from urban to rural populations. And please keep in mind that this is covered population. So in 2015, all these people could have breast cancer screening without paying out of pocket, and still they didn't have it for many other reasons. And we know that people have many more reasons not to access healthcare services, but that means there is still a lot of work to be done. Again, when you look at the reports, you're going to see a huge variation in some specific counties and regions in the state. Okay. The last report that we released was condition prevalence, and this includes asthma, breast cancer, chronic conditions like diabetes type 2, hypertension, COPD, and also some cancers. Most of the measures reported here are estimated for the adult population, with the exception of diabetes type 1 and asthma, that are also estimated for children. And these measures are reported as percentages, and the methodology behind this is the ACG software from Johns Hopkins. And what makes a person be included in one of each categories is to have a diagnosis for healthcare services during the reported period, and they need at least 2 diagnoses to be considered in the bucket of diabetes or hypertension. It is also important to mention that if a person has diabetes and also hypertension, they are counted in both. They are counted in diabetes and hypertension, and that's actually, unfortunately, common enough. The highlights of this report are: 1, hypertension is the condition that was diagnosed with most frequency in each calendar year, and that is not surprising. Medicaid population has the highest prevalence. Another highlight of this report is the increase in depression and the prevalence of depression, and that probably is due to the statewide initiatives improving screening, systematic and universal screening for depression, which of course seems like we have a problem, but actually we are identifying a problem which hopefully we can solve. If the first step to solve something is to identify it, and I think in this case, having a higher rate of depression might be the first step in the right direction. And the other highlight, of course, and I think that this is not surprising, is that depression tends to be higher in female populations than males. It is also much higher in specific counties in the state. Again, I encourage you to go and look at the maps. And now that we go over all the 4 reports, again, I want to invite you to go and look at the interactive reports. You can look at the reports whether by geographic location, by county, or health statistical region, but also you can look at your population segment of interest. If you're interested in looking at what is happening with population 65 and older in rural communities, you can go and look at that, or you can go and look at 0 to 17 population or to younger adults. That is important. Keep in mind what is represented in these reports and try to look at the numbers within instead of comparing to other prevalences that have been previously reported. And look at these pieces of information and another piece of the puzzle to understand much better the healthcare system performance, and another tool to start building a plan of action of improving healthcare for everyone. Okay. Oh, I forgot the cancers. I'm sorry, but the cancers is they are much more prevalent among older population as the other chronic populations, with exception of depression, and that's important to note. And breast cancer screening is by far the most prevalent. Okay. What is going to be updated in the fall is we're going to be adding some other measures to the same reports and some other reports. For example, for cost, we are going to be adding reporting cost by morbidity or by illness burden using the ACG methodology. We're going to be adding some service categories to the utilization report as professional visits and potentially preventable ER, which is a subset of ER visits. We will be adding some quality measures that are listed there. For example, people who have diabetes and have appropriate eye exams, or appropriate treatment for children with upper respiratory infections. We are also adding some measures of access, which is very important. As you can see, the difference in preventive care rates and treatment might be also, or might be very closely related to the access that people have to health services. And we are going to be adding also some other condition prevalence measures like generalized anxiety disorder and teen pregnancy rates, which is considered a very important population health outcome. Asthma exacerbations also. Oops, I'm sorry. Okay. I missed one. Okay, and also very important, and this is, we are adding, as you can see, the reports are presented by payer for commercial payer and for Medicaid and Medicare Advantage. But in fall, we will be adding Medicare fee-for-service as another category of payer type, and that will add a lot of the reports, and we will be also adding more years. Hopefully, we can go all the way to 2017 in late fall, and then let's say catch up with the most recent years from then and forward. And another thing that we're going to be adding to the reports is downloadable Excel files, so you can get the data down to your desktop and work with it and use it to prepare reports or anything you want. Okay. The upcoming update in late summer will be a consumer-focused report, and in this report we will be displaying the price and quality for some imaging services and also some surgical procedures. And this is the format that the report will have if you are a consumer and you are looking for what would be a good place to have a knee arthroscopy. You can enter your zip code and look at the different facilities that can provide that service, and then you can look at the median price of that specific service. And if this is a hospital-based service, hospital-based facility, you can have also a 5-star hospital quality rating and a 5-star also patient experience rating. And the next slide shows the imaging services that are going to be part of the facility level report. The imaging services were selected based on the frequency that these services are done, and also based on the price that some of these services have. And the surgical procedures were selected also because of the frequency, but because of the feasibility that this is a service that some consumers can shop for. Like if you have a heart emergency, you are not going to shop for that. But if you need that cataract surgery, you might have the time to actually look for the best price with the highest quality that is available to you where you are living. And so that's the base for selecting these procedures. And this is coming in the summer, as I mentioned. And with that, I'm going to go back to Carrie, who will talk about other type of public reports. Thank you.
Thank you, Maria. And at the end of my next session, I will go ahead and pop out to our website and show you some of those interactive reports, so you know exactly where to go to see the data that Maria was just talking about. So thank you, Maria, for going over that. So a couple of spot analysis that I want to review. The first one is one we just released in February, and we actually did a whole webinar just on this topic. So we're going to go pretty quickly. There have been a lot of questions, and I'm sure we could probably spend a whole another hour on that, but we do have that recorded on our website if you're interested in learning more about this total cost of care project. But this is also a white paper available on our website. It's a project that we did nationally with the Network for Regional Health Improvement Organizations, ENRI. We were part of this project with Oregon, Utah, Minnesota, and Maryland. And the bottom line is that the big green box on your screen is that Colorado's costs are 17% higher when you look at risk adjusting our patient population and using the same methodology in those other states. And those arrows, blue arrows, are pointing to the drivers. And I think this is one of the very exciting things about this project was that it actually broke it down. So overall cost was broken down into what's driving the cost. Is it utilization and resource use, or is it price? And for Colorado, we were both higher in resource use, which is that blue box on the top, And then we are also higher overall for our prices of the care that people are receiving, as opposed to the other states. We're that first column. You can see Maryland is lower on the price and the resource use, and can see the other states, how they compare. Interestingly, Oregon is kind of on both sides of that, so they had higher prices, but their lower utilization kind of balanced them out and brought them closer to the actual zero, the average across all of those states. So in addition to just the overall, how does Colorado compare, we did in our white paper an analysis of the different regions across Colorado. And as we were mentioning earlier in all of our public reporting, we see very, very wide variation in cost and utilization and conditions across the state, depending on where you are. So, you know, everybody says healthcare is local, so is all the variation and the differences in healthcare. This breaks it down into what is driving costs in each of the regions across the state. So if you look at that first row across the top, you're looking at the east part of the state, which you can see in the dark blue in the little map down at the bottom. Those are all of the counties that in regions that encompasses, which is quite a wide area. But they have the highest cost per member per month. And that's driven by 8% higher utilization in that second column, and then also a 21% higher cost than the statewide Colorado average. And keep in mind that this is looking at their cost and their utilization compared to Colorado. This analysis was not done by region compared to the rest of the states that were in this data set. On the flip side, you have Colorado Springs in the bottom row there. They have the lowest cost per member per month compared to the rest of Colorado, driven by both 8% lower utilization of healthcare services and then also 6% lower prices. In the middle there, you see Pueblo and Boulder kind of on closer to the statewide median, but they have higher utilization, but that's being balanced out by lower cost. So another kind of interesting way to look at this data, it's all based on patients that were attributed to primary care practices across the state. And there were 122 or so primary care practices. This graphic right now, each blue dot that you're seeing is representing the 112 adult primary care practices. The pediatric practices are not included in this graph right now. But what we wanted to show was for all of the care for patients attributed to those practices, and it's not just the care that those practices are providing to those patients, but it's all of the care that those patients get, including primary care from those practices. You are seeing the wide variation in price and utilization across those practices. So down in the lower left, we would want everybody ideally to be, you know, closer to the lower price, lower utilization quadrant. But we see very wide variation across the state, and people, some are in low price, high utilization, some in the upper right-hand side are high price, high utilization, kind of where we wouldn't want most patients to be. And then we also have high price, low utilization as well. So we have a lot of opportunity. The other exciting thing about that project is that the funding that we got was through the Robert Wood Johnson Foundation. And part of that project, we provided detailed reports to the practices who are involved in this so that they can see where their patient population has opportunities. They have opportunities beyond their wall where their patients are going might not be the most effective as far as their referral patterns might be driving costs up for those patients. So very exciting stuff. We're in the third year and we're continuing that project. Part of the reporting that we'll be doing for this next phase will be more public reporting on the practice level to show how variation happens across the state in a little more detailed fashion. Some other spot analysis I just want to run over. I'm not going to go over all of our publications that we have, but I just want to highlight some of the latest ones that we have released. This one's on pharmaceuticals, so we have pharmacy claims in the APCD. We did this analysis based on some media attention that these two drugs in particular, Vimovo and Juexis, have been getting across the country actually. They're over-the-counter drugs separately. So both of them have the equivalent of an Advil and Peptid combined. So it's things you can get off the counter for about $40 for a 30-day supply. But when you purchase the combined version, which is a prescription only, it costs upwards of $1,500 for a 30-day supply. So we wanted to know what that impact was in Colorado, since that drug was released or these two drugs were released in 2012. We've spent over $24 million in Colorado on those two drugs alone. You can see the lower box down there shows commercial payers have kind of stopped paying for both of those drugs. In 2016, you see Medicaid, and there was a spike in 2014, 2015. It's coming down in 2016, but it looks like they were still paying for those over-the-counter drugs that are available at a fraction of the cost. So that's a cost savings opportunity potential in the state. Another analysis, this is actually combining two spot analysis that we did. We did one specific to freestanding emergency departments, which have gotten a lot of attention nationally and locally. That top section up there at the top that shows the blue boxes, those are all reasons that people are going to either urgent care, or the next column is, or the next row is freestanding emergency departments. The bottom one is hospital-based EDs. The blue are reasons that are non-emergent. So you can see most people are, the top 10 reasons going to urgent care are non-emergent, which is what you would expect. For freestanding emergency departments, when this analysis was done in 2014, 7 of the 10 were for non-emergent reasons, as opposed to hospital-based. Only about 3 of the 10 were for non-emergent. Ideally, we wouldn't have anybody going to either a freestanding ED or a hospital-based ED for things that are non-emergent, but it happens, obviously. We want to minimize that, because the potential cost savings if people didn't go to the ED for things that are non-emergent would be about $800 million a year. You have about $1,000 plus costs on top, on average, when you use the ED for things that are non-emergent. This payer variation analysis is also on our website. This is looking at the Medicare Comprehensive Joint Replacement Bundle Payment Program that was put out a couple years ago now. This is an analysis of that joint hip and knee replacement bundle. If we look at all of the costs associated with hip and knees, pre and post in the defined CMS methodology, and looked at regions across the state and how does that compare to the Medicare rate. So you can see Northern Colorado, that bundle on average is about $78,000 compared to Medicare payments for that is $23,000. In Denver, it's much lower. Commercial payments are around $39,000 compared to $22,000 for Medicare. So payments can be up to 232% more than Medicare. So another potential, thing that we need to be aware of and cognizant of, and perhaps look into a little bit further on potential cost savings. Another prescription analysis, this is a data bite that we have available on our website. And just so you know the difference between what we call a data bite and a spot analysis, a spot analysis has more text and context around what it is, usually a 2-page analysis, whereas a data bite really is just snippets of data without a lot of written text and context. But data bites requests come to us in a variety of different ways. Sometimes we get them from an advocacy organization. Sometimes a legislator asks us for information, or a reporter might ask us for information. And if it's under 8 hours of analytic time for us, it can go through our data bite process, which gets approved by our advisory committee for the Colorado All-Payer Claims Database. This one was on Subsys, which is a very heavy-duty opioid that's only supposed to be prescribed according to the FDA for instances where patients have a cancer diagnosis. But because of some unfortunate things that this pharmaceutical company was doing to provide kickbacks to some physicians across the nation, they were seeing spikes in the prescribing of this particular drug when it wasn't necessarily warranted with a cancer diagnosis. So we looked at the claims in the Colorado APCD between 2012 and 2016, and of the total Subsys claims, about 78% of them did not have a related cancer diagnosis during that time period. There was a spike in 2015, and if you go to our data bite, it actually shows the trend as well. But that equates to about $13.6 million that was potentially avoidable by not prescribing this drug, not to mention probably on the flip side, more importantly, patients were receiving this very strong opioid and not necessarily warranting it. So that's another thing that we need to be keeping in mind as we move forward is the appropriate use of medications, which is another great use of the CO APCD data. Another data bite that we did based on the potential changes in the ACA recently over the last year is looking at what would the impact of pre-existing condition, removing that from the ACA, what would the impact potentially be here in Colorado on the number of Coloradans that have pre-existing conditions. And when we looked at just Medicaid and commercial plans and included everybody that was on our Connect for Health Colorado Health Exchange, 840,000 Coloradans have a pre-existing condition in that population. That equates to about 20% of all commercial and Medicaid patients. So huge impact potentially if that had gone away. Another one that was related to potential changes in the ACA, we were asked by the National Academy for State Health Policy to help them understand high-risk pool benefit in the ACA and the potential if that high-risk coverage in the ACA went away, what would that cost look like as far as states needing to figure out a way to cover these individuals. When we looked at the APCD data, if you look at the top 2% of individuals who have the highest costs, it costs on average about $78,000 to cover those individuals in the high-risk pool, and that equates to about 41 of the rest of the folks covered in Colorado. So you can see the Colorado high-risk bucket at the top there compared to low-risk price per year. This is an annual by per year rate, and then New Hampshire and Virginia are fairly close in that same, using the same methodology as well. So cost to cover in Colorado and in other states is quite significant. And this, I think they were just trying to prove the point that we need to figure out a way to still continue to cover those individuals, because the cost would, obviously, I wouldn't be able to afford covering myself, thankfully. I'm not in that pool, but I don't think anybody in that situation would be able to cover themselves. So another data bite that we did recently was emergency department trends. This is showing the severity level trends. So it's looking at all ER visits from 2009 to 2016. This is in just the commercial population, and it's looking at trends in the severity levels. The orange bar is the high severity life function or life-threatening codes that are used in the ED. And then compared to, if you go all the way down, the lowest severity is the tinier purple box. So you can see the trends are that the orange is increasing, so more patients are being coded or coming in with high severity, life-threatening conditions, as opposed to the lower severity is actually shrinking. We have this data bite available on by commercial and then also by Medicaid and Medicare Advantage too, so you can see that on our website. A couple other things real quick. Other spot analysis that we have hepatitis C quality measures information for the SIM program in Colorado. We also have geographic payment variation for common health conditions, C-section analysis, as well as some data bites, frostbite with subsequent amputation, EpiPen cost trends, and teen pregnancy trends in Colorado as well. And I will show you our website here in just a second of how to get there. But before I do that, I also want to mention also on our website, you have information about all the custom data recipients. We get a lot of questions about how are people using custom data from the APCD. We do provide custom information. You can see all of the ways people are using it. This is just a snapshot of all the organizations who have used APCD data. We've provided hundreds of custom analysis, and we have several ways that we provide those in standard reports and data sets, custom reports, or data extracts as well. let me actually flip out. While I'm going to our website, I just want to remind folks that you can type in questions in the Q&A box, and we'll be taking those here in just a second. So the civic.org site is just CIVHC.org, and that's where you can get all of our public information. If you go up here to the Get Data tab, we have just overview of the APCD in general, but the Public Data tab is what we've been talking about today. So if you click over to the interactive data, you have a number of options. We have the Shop for Care tab is where the information that Maria was talking about on the facility named price and quality basis. The imaging services will be live this summer. If you scroll down to the rest of these, the cost of care, condition prevalence, quality, and utilization, these are all the reports that Maria went over that are interactive. So I'll click on the cost of care just to show you what those pages look like. Each report will have considerations to keep in mind. As Maria said, you know, we're not looking at Colorado comprehensively because we don't have every single person in the claim, so you have to be cognizant of what data you're looking at, so that the considerations parts just kind of remind you of the things to be thinking of as you're looking at the data. We always have the insights document as well that will give you kind of a 2-page snapshot of what we've found to be interesting in the data. You can download that. And then the interactive report is also on this page. And as Maria mentioned, you're always going to have an overview in each of these interactive reports. Always we start with an overview just to give you the high level. In the instance of the cost of care, you have ways to slice and dice the data looking at the health plan and patient cost, or the health plan only cost, patient only cost. We always have years available. A lot of our reports, you can break it down by different age groups and also different genders. And then here you'll have output right away based on statewide, rural, or urban. And again, as Maria mentioned, these are broken down into the types of claims that you can see. It's not wanting me to move away from that. Inpatient, outpatient, professional, and pharmacy. If you hover over those, you can see all that information. It's also in a table form for you. The second tab is always going to be your trend information. So it'll show from 2012 to 2015 at this point. As we mentioned, we'll be adding 2016 and 2017. The percent change is calculated from 2012 to 2015 so that you can see the variation there. And you also have some graphic representations of the trends. And then I think what's really exciting for those of you in doing specific county work or statewide work is being able to also look at the maps and the geographic profiles. This takes a little bit longer to come up. It spins for a minute because there's a whole lot of data behind these, but if you have a particular either county, or you can also slice and dice it by health statistics region if you'd rather look at HSRs. You can select a particular county. Let's say you're interested in, I don't know, Clear Creek. Let's pick Clear Creek. You can see costs across all payers for Clear Creek, and then that compares right away to statewide, urban, and rural right there, similar for the different payer types. And then down here, you can also look at your ranking as a county. This statewide ranking goes high to low. So it's showing Pitkin has some of the highest costs in the state compared to Hinsdale has some of the lowest prices in the state. And then those maps are all there. You can also just isolate to a particular payer as well. So that is where our interactive data is. And if you're looking for our publications, more of those spot analysis and data bites, those are also under the public data, but you would click on the publications tab. We're always going to highlight the top 5, or I shouldn't say top 5, I should say most recent 5. They're all top in our mind. But the most recent releases that we have had for publications, including our annual report. I didn't mention our annual report, but that has kind of a comprehensive look at all of the data that is available publicly, and then also features change agents and how they're using the data. So definitely check that out if you haven't already. And then at the bottom is where you can find all of the different spot analysis and graphics, all of the different data bites, and then all of the past annual reports, as well as other resources too. So I will leave that here. And then the change agent gallery, as I was mentioning, is also one way to understand how the APCD is being used beyond just public reporting. We also have community change agents, which aren't necessarily using APCD data, but they are doing fantastic triple aim programs across the state. We also do a chat every month. Those will be changing to some podcasts and more often, more frequently coming up, but all the chats that we've done in the past are also located there. So those are interviews that we do with our change agents to go into more detail about their programs. So it looks like we have some chats and some Q&A. So I'll start with the Q&A. The question is the lower cost and utilization in the Colorado Springs cohort partly due to the lack of data from active duty and retired military? That's a good question. I don't know that we've looked into that. You're right that we do not have the VA information. But even if you look at the same, it's looking at commercial payers. So we're looking at the same patients across the entire state. So I don't know how much that information would impact, or the lack of TRICARE or VA impact. We have our, Tamian Osborne Roberts is here. You can't see him right now, but he's sitting right next to me. Or maybe we could swivel it around, but he's going to address that.
I can certainly speak from off camera as well. Or on camera, hello. How is everyone? Overall, no, there certainly is a gap there. But a more interesting pattern, I think, emerges once you start looking at the state as a whole. If you look at all of the various areas that, while still overall high cost, or lower cost within the state of Colorado, you start seeing a pattern emerging that looks like Front Range versus everyone else. And I think while there may be certainly some effect and a data artifact from missing TRICARE and VA inside of Colorado Springs, you really do see an overall effect along the Front Range versus the other portions of the state. And I think that could be explained in a number of ways that could be looked into more deeply. I won't speculate here today. I've had some thoughts on it. I'm sure you do too. But overall, it's something that we'd like to be able to remedy in the future with that data. We just have to get to a point where we can get it.
Okay, thank you for that question. And Doug McCarthy asked if the shopping tool that we're going to have will have actual prices that might be paid by consumers. So what the prices will be, Doug, is they will be median paid amounts that the plans were paying. They will include the patient portion as well. So they will give the total cost. So it won't necessarily be, what my plan will charge me based on my deductible and coinsurance, but it will give the price that I would pay between me and my insurer. And then at that point, it's to highlight that there is variation in where a patient might go and that they should be considering where they go, because prices are very different depending on where you access care. And then we'll have, encourage people for specific prices for them based on what their coinsurance and deductible is. Of course, we want people to go to their actual insurance company. A lot of health plans already have tools like this available. This is just another way to educate folks that there is a difference between prices and quality, and that they should be shopping for healthcare services. And it looks like I don't think we have any other questions at this moment. Again, if you do have any questions at all, please type them into the Q&A or into the chat box. We can find them either way. Okay. So we have one quick question. What kind of engagement have you seen from your public reporting efforts? That's a great question. It kind of depends on what we release. We've gotten a lot of attention from the freestanding emergency department information, even nationally. We've had reporters contact us because that's something that they don't have data. There isn't a lot of data out there on freestanding emergency departments, so that has gotten a lot of engagement and a lot of excitement from folks just trying to understand that space. As you might be aware, there was legislation that was actually passed this year on freestanding emergency departments, and that data that we had in combination with other data sources was used in some of those conversations. So, and the cost of care information, especially the total cost of care, white paper has garnered a lot of good conversation from the policy level at the state, lots of interest with representatives and senators on how do we address some of that variation that we're seeing where Colorado is an outlier, and then also on the community level where practices and docs are really interested, and even hospitals are wanting to know what does our patient population look like. So there's been a lot of engagement. It just depends on the analysis and where people are in their projects and initiatives and what's at top of their mind. So that's why we would love more input from all of you on what information would be helpful for the work that you're doing, so that, because we don't want all of this to be shelf paper. We don't want it to just sit there and never get used. We want people to be looking at it. So the more we can address things that you guys are questioning or that you're interested in, always, and it doesn't just have to be today, we're here all the time. So, let us know if you have an idea on what might be valuable to you. We would love to address those needs as they come up. Okay, here's another question on the total cost of care project, which is seriously, we get a lot of questions on this. And again, Tracy, thank you for this question, but I will point you to the webinar too in case we don't answer all of your questions regarding this report. But it's how do you handle capitated payment in your total cost of care calculation? Is it a fee-for-service equivalent, or do you allocate the capitation payment in some ways? So in this latter instance, it does reflect real payments, but there is some estimation in their allocation. Did you want to address that again?
I could. Hello all again. So taking a look at that, and at this point, it's only actually since this year that we've been able to receive what I call alternative payment model information.
We don't have.
We're still working on that.
We get a fee for service.
Right.
Equivalent from one of the payers who doesn't pay on the fee-for-service model, but we do get an equivalent from that payer. That payer was actually not included in the total cost of care project. We are working on getting APMs, the alternative payment models, into the database actually this year. That'll be part of the data submission guide rule change that we are working on this year with HCCLS, that we have an annual rule change that alternative payment models is going to be part of. So I believe they were all fee-for-service equivalents, and we can confirm that with Jonathan, who is our lead on that project. But I know Kaiser, for instance, was not a part of the analysis because of the way that they do their claims.
And that's my understanding as well. Something to point out is, first of all, thank you for asking the question, because I think it's important to think about how much goes to inpatient, outpatient, and whatnot. But what I would say is that as new models come in, for instance, in our initial work, working with Kaiser to try and find a submission model that would work, we had to make changes, and the data that we get from Kaiser is used in a similar but different way. It has a different lens on the interpretation than some of our other data. As the payment models that we get become more diverse, it will be less about standardizing between all of them, in some cases about standardizing within, and at the end of the day, we're always looking for how to answer interesting questions. So as of yet, that's not something that we've had to consider. It is on our radar to consider in the future, and as you have ideas as to how we might do so, once again, we would love to hear from you.
Okay, so it doesn't look like we have any questions, and we're almost at the top of the hour, so we want to be respectful of your time. And thank you again to all of you for joining us today. As a reminder, we will be posting this recording along with the slides, and then also that summary document I talked about that has a listing of all of the public reports that we have and kind of a snapshot of what you get, so that if you're ever wondering, you can use that as a resource, or again, feel free to reach out to any of us here at Civic. If you're not sure who to reach out to, just contact us at info@civic.org. I can put up our information here one more time. Maria and I would be happy to also answer any calls that you, or any questions that you guys have. Anytime you guys have input and ideas too, please send them our way. And thank you again for joining us, and have a great rest of your Monday. Bye-bye.